Why do surgeons sometimes take out the exact metal that fixed your broken bone? Is it a routine step or a risky choice? Today, we break down 5 real reasons implants get removed and the evidence behind when removal helps versus when it may do more harm than good. Welcome to Ortho Implants for Life, your one-stop destination for all orthopedic implant industry-related information. And today, we're discussing 5 reasons to remove orthopedic implants. Disclaimer. Before we get into the topic, let me remind you that this video is for education only. It's not medical advice. Implant removal decisions must be individualized. Talk to a qualified orthopedic surgeon before acting. So let's start. Why this question matters? Orthopedic implants, plates, screws, rods, nails, wires have helped millions heal. But removal is a common topic. Some patients ask for it, some surgeons recommend it, and the evidence is mixed. Understanding why implants are removed and what the data says can help patients and clinicians make better choices. Let's walk through the top 5 reasons implants are removed, with numbers, risks, and practical context. Reason 1. Pain, soft tissue, irritation, prominent hardware. Pain, prominence, or soft tissue irritation. This is the most common reason patients request removal. Multiple studies report that pain or discomfort accounts for roughly 30 to 42% of implant removals. One tertiary center study found pain was the leading indication at 42%, and another large review showed patient request or discomfort as the most frequent cause. Why it happens? Plates can sit close to skin or tendons, clavicle/superficial ulna/forearm, causing irritation or a catching sensation. Older, bulkier hardware is more likely to produce symptoms. What to expect after removal? Many patients report symptom improvement, but relief is not guaranteed. Some pain persists because other factors, scar tissue, nerve sensitization, or arthritis, can be the real cause. Reason 2. Infection. When an implant becomes a focus for infection, acute or chronic, removing the hardware is often part of definitive treatment, especially if the infection involves biofilm on metal. Numerous reviews and clinical protocols list infection as a universally accepted indication for implant removal and revision. So basically, early deep infection may sometimes be treated with debridement and implant retention plus antibiotics. But chronic infected implants often require removal, temporary antibiotic spacers, and staged revision. Leaving infected hardware risks persistent osteomyelitis or systemic complications. Reason 3. Implant failure, mechanical problems, migration. Hardware can fracture, loosen, or migrate, especially when used in the wrong mechanical setting or after trauma. Mechanical failure is an accepted reason for removal and reconstruction. Studies and case series regularly list implant breakage, loosening among the top clinical reasons for removal. Reason 4. Allergy or metal hypersensitivity, or simply the patient's preference. Some patients have local reaction or systemic symptoms attributed to metal, and in a subset, implant allergy testing or clinical picture leads to removal. Reports indicate nickel allergy is relatively common in the general population, and implant-related reactions are a recognized though uncommon indication. Patient preference, psychological relief, elective removal for peace of mind or to avoid metal detectors for personal concerns is common. Some studies report up to 35% of removals are elective or patient-requested. Reason 5 is largely pediatric. Planned removal to avoid growth disturbance. Children's implants, especially K-wires, elastic nails, or plates crossing physes, are often removed deliberately to prevent growth arrest or to allow further growth. Pediatric orthopedics commonly schedules removal once the fracture is united and growth risk is managed. Summary of the 5 reasons. So to recap: pain, prominence, infection, implant failure, migration, metal allergy or patient preference, and pediatric/growth-related planned removals. Those are the 5 big categories, but the decision is never automatic. The big question: is removal necessary? The evidence. Now the tough part: is routine implant removal necessary? Short answer: no, not routinely. Most modern orthopedic guidelines and systematic reviews advise against routine removal of asymptomatic implants. The evidence shows mixed benefits and measurable risks. Evidence and numbers. Several large reviews and studies, AO literature, systematic reviews, conclude that routine elective removal of asymptomatic implants is not supported by robust evidence and may expose patients to unnecessary risks and healthcare costs. Refracture risk after removal varies by bone and implant. Reported rates range from about 2% in some modern analyses to up to 9% in older or pooled data, depending on implant type and location. Forearm plates show higher refracture risk after removal. Recent studies, forearm plate removal linked to higher refracture in some cohorts. Overall refracture after removal in some series approximately 2 to 4%. Other risks of removal: infection, nerve injury, incomplete extraction, non-union or refracture, additional anesthesia, costs, and recovery time. So when is removal justified? Symptomatic implants, pain, prominence, infection, mechanical failure, clear allergy, and in children when growth risk exists. Elective removal of asymptomatic implants is controversial and largely discouraged unless compelling patient reasons or surgeon judgment indicate benefit. How surgeons decide. What goes into the decision? Surgeons weigh symptoms. Is the implant clearly causing pain or dysfunction? Risk of removal. Is the bone strong enough post-removal? Is the implant well integrated? Anatomic site. Implant removal in forearm bones and tibia carries different refracture risks than clavicle or olecranon. Patient factors: age, smoking, osteoporosis, activity level, comorbidities. Alternatives: can symptoms be managed conservatively? Physio, analgesics, local steroid injection before removing hardware? In many centers, a shared decision is used. Explain risks, show data, and plan timing to minimize complications. Implant removal is not a one-size-fits-all decision. For symptomatic problems and infection, removal is often the right move. For asymptomatic, well-functioning hardware, the evidence warns us watchful waiting is usually safer. If you're a patient, ask questions. What are the risks? What are the alternatives? If you're a clinician or device professional, understand the data. It'll help you guide patients wisely.
If you have enjoyed the video, like it, share it, and if you are new to our channel, subscribe it. Hit the bell icon to get notifications for all our upcoming videos. Join us to excel in this orthopedic implant industry and to know more about the job and career growth which is available in this industry. Thank you. See you again next week.